So I confess to having a little bit of a heart sink moment when I was asked to talk about apps, because I'm a bit of an app skeptic. I think there's a huge amount of talk in the NHS sort of innovation bullshit circles about apps and how that they're going to save us from ourselves and help patients fully deliver self-care, and they're even going to save us through this next winter crisis. We're going to use technology and apps. It's going to be wonderful. And so I find that very, very difficult to swallow. And I think there is a huge way to go before we get to the stage where I can stand here and recommend you some really great clinical apps that are going to make your lives as GPs a lot better. However, I've got some things that I can talk about. He's done all that bit. I actually sort of ran some of these by a couple of colleagues, and the first thing they said was, why would we use the app for that? Why wouldn't we just Google it and then use the first hit on, or we know we have on our bookmarks all those links that we use commonly. And I think that's absolutely valid, because as GPs, we are really fairly consistently in front of a terminal which has got a good internet connection most days, and you can just Google for whatever you want. And so a lot of the stuff that really has much more compelling use cases for mobile doctors, hospital doctors, out-of-hours GPs, and that sort of thing. And they're even less well supported than we are. So in a way, we could say we're quite lucky as GPs that we have what we have. There are, however, a couple of interesting apps and some interesting stories as well. So it's not that long ago that there was no BNF app. There is now quite a nice BNF app. This one you can just download, and it replaced the previous two apps, which were the BNF-C and BNF app. So there were two different BNF apps, which required an Athens login to get. So just that little hurdle that you've got to go through before you could get it. Now it's much more straightforward. You just download and use the new BNF app. Before those apps, this is about 5 years ago, the BNF was refusing to have any form of open access to that public resource that has been created by the contributions of many, many thousands of patients who've had adverse reactions and had to go through that pain, which we've reported through our yellow cards, back to a profit-making organization who have gone, thank you, we'll just have that data, we'll sit on it, we'll charge you for it. Hang on, charge us for it. So it actually took NHS Hack Day to shame them into producing an app. And so the NHS Hack Day obtained access to the BNF, which at the time you had to do through either an N3 connection or you needed to sign in, scraped the entire content and put it on an open BNF website. And they did that in September 2012 at NHS Hack Day 2. And after that, there were some very interesting conversations between the Royal Pharmaceutical Society and Informa, who owned BMJ, who produced the BNF. And gradually their stance has moved to the point where we've got this. So quite straightforward when you look at it. And it's actually a very nice app. You know, you can search for content and you can read it and you can do things with it, all the things you'd expect kind of thing. And it's in your pocket, so it's great. You know, it's much more convenient than carrying the paper thing. And it's offline content as well, so if you don't have a good data connection, it does work. But it's just interesting to know the backstory as to how that got there. It's also quite empowering because it makes you think, when we are in situations in the future where an organization is doing similar things and not doing the right thing clinically for our patients, we can make them do it. We have moral upper hand. And sometimes we do something that may not appear to be legal in the case of this, but actually, you know, the consequences were the right thing happened. So stick your neck out, it sometimes works. This is a slightly more interactive app. I use it a fair bit in my emergency medicine practice, but also in GP. There is a website, MDCalc, and this does the same thing as the website. You can work out an ABCD2 score, and you can work out a CHADS2 VASC, and you can work out various different scores to help you manage the patient. Another free app, another interesting one, very useful. Talkspace, they're another interesting story. Their first offering was 60 quid, and it was via partnership with a company called Skyscape, who basically just wrap up content in an app and then put a paywall in front of it. And then they've actually changed their tune, and now Talkspace have got a free app, and you just need to sign in with a Talkspace account, and you can see the stuff. So at least that's now made it easy for, say, an emergency physician to actually use Talkspace in their pocket, as opposed to wandering around the A&E department looking for a free machine to look up a Talkspace reference. And it does have a quite helpful calculator as well. I think one of these is a calculator for paracetamol overdose, which is probably the most frequently used antidote and just a nightmare in terms of the calculations you've got to do. I mean, it's all doable, but why would you do it manually when you've got a computer that can do it? As long as it's been programmed right, it's faultless. Guidance. So the sign guidance, they were very early to the table with apps. Scots obviously are a little bit more forward-thinking than the English, and there are lots of Scottish informaticians who would agree with that. So they came out with all their sign guidance very early on in an app, offline. Brilliant. NICE have done the same, but it's taken them until just this year, I think, that their app for guidance came out, or it may have been at the tail end of last year. So some clinical stuff. Is any of it very exciting to you, given that you could have Googled all of that? And you know, there are some others, they're also equally reference-based. And that's the pattern, really, is that, you know, MIMS, NICE Guidance, Credible Meds, iResource, there's just not much interactive. And I find it more interesting, that's what I'm going to spend my time on, telling you is why I think that is. Okay, but before we go there, some actually essential apps if you are a busy GP, all right? These are the things that I will stand by and say you need to get, okay? So this is a password manager, LastPass. There are other password managers available. There's KeePass and 1Password, and there's a whole load of them. It doesn't really matter which one you go with. Find one that suits you. But it always makes my heart sink when I speak to people who have got password fear. They either forget their passwords, so they're fearful of just generally the web because they know that they won't be able to work it because they've forgotten the password. They haven't used that thing in ages, and they can't remember which of their 5 rotating passwords they use. It's like disastrous security. And you know, we are healthcare professionals, and if we're to be trusted with medical data of our patients, we need to actually sharpen up our personal practices about managing security. So I personally use LastPass. My password length is usually between 25 and 30 characters, all random. Not one of my passwords is the same as any of the other ones, and I don't know any of them. I only know the master password for LastPass, and that gets me in, and then I can get them all. I can get them on my phone, I can get them on any one of my computers. If I am on a strange person's computer, I can install LastPass within 10 seconds, and I'm using it there, and you just sign in, and you've got all your passwords. But it means that if any service that I'm using is hacked, and these things happen even to the biggest of the big, you know, Equifax were hacked this month. Sony, one of the largest hacks ever, Yahoo. So anybody with an account anywhere with these, any big provider that gets hacked, they have your email address usually, and they will probably have some idea of what your password might be. They might not actually have the password in clear text, but they can often work it out using technical mechanisms. But they will then go and take that password and try and get into your iTunes account or your Apple account or your Google account using the email address they know that works for you and some passwords. And they will also just try random passwords. There are lists of the top 10,000, the top 100,000, the top million passwords, and it's very quick for them to just try them all. So using different passwords for every single service you use gives you a layer of security. So it means that if one of them gets hacked, it doesn't matter. I just change that password, none of my others need to change. So that's top of my list, is like get a plan for passwords, okay? It's not someone else's responsibility, it's yours. This is just LastPass on mobile. When I'm signing into an app, it's showing me, it immediately pre-populates the password and everything, so I don't even have to do it on phones. It just tells me, so get Pocket, click on that, it will pre-fill, and I press login, and it just does it. So it pre-fills the login details on your browser as well as in mobile. So if I sign into something that I'm not signed into for a while, it's virtually instantaneous. It just flicks through that bit and I'm into the app. So it just saves me a lot of time. This is it generating a random password for me, so I can choose the length. I can say uppercase, lowercase, numbers, special characters. I can even say make it pronounceable. So occasionally you want something that you could actually tell somebody. And so you can make something that's still random and gibberish, but it's pronounceable, as in it's got the right sort of vowel and consonant ratios. Okay, so LastPass, get it, or get something. I use Trello a lot. Trello is a very simple Kanban app. Kanban is the process of managing demand. It's actually invented by, it was invented at Toyota in the 80s for managing their production lines so that there would always be, everything would be in the right slots. So you'd never run out of bolts, because if the person putting the bolts in runs out of bolts, if you can't reach for a new bolt, then the production line, the whole thing has to stop because there's nowhere for his car to go to because it hasn't got a bolt in, etc. So they devised a way of making sure that supply chains were absolutely seamless. And they used this thing called Kanban, which is just essentially Post-it notes on boards, is a way you could sort of represent it. And so this allows you to have these little cards, which this is my shopping list, things that I need to buy for the garden for next year. I've got a shopping list, I've got one for my business, I've got one for everything, which is like an overview. And you can drag and move these cards around. So you could maybe have a list for things you need to do, things that are in progress, and then things that are done. And you drag it across to in progress, and then you drag it to done. The really nice thing is you can share it with a team. So you could have a practice Kanban and say, these are the projects, or this is the meeting. So we decided these things at the meeting. This is where we're up to now. Then when you get to the next meeting, you say, okay, well, those didn't get started from last meeting. So whose action point was that? It's not been moved on. And you can use it to monitor where you're up to with things. You can use it between, as I've shown you, me and my wife have a Trello shopping list so that if she puts things on, or say I'm out at the shops, she could add something, and it's instantly synchronized. So I will still remember to get it, even though it's just been added at the last minute whilst I was still in the shop. So, yeah. So there's loads of little things you can use it for like that. And because it doesn't really impose much structure on you, you can use it for whatever you like. People use it as all kinds of content management things and stuff like that. It synchronizes to the desktop app as well. It's all free. You pay to get some premium features like different colored backgrounds and stuff like that, but really nobody needs those things. This is a slightly different style of app. This is starting to get to where I would like to see clinical apps being in 10, 20 years' time, because I think it's going to take that long as well. The innovation people might say, oh, we can have it yesterday. We just need to all sing the song of innovation and hold hands at EHI Live, and it will happen. No, you actually have to build the infrastructure, and that stuff doesn't just come with wishful thinking, okay? So the infrastructure has been built for a lot of these web services, and that's why we've got if this, then that, which is what IFTTT stands for. So it means I can get any of these services, there's just 8 there, but actually if this, then that works with something like 200 different web applications and websites and web services. And it allows you to wire them up. So you can say, when my phone reports my location as being at home, you can switch on my Philips Hue lights, which are Wi-Fi controlled Internet of Things lights, or you could use any other input. So you can control, so in this case, an RSS feed, which is a kind of syndication feed for a website or something. Whenever there's a new Hacker News, it will put Hacker News in my Pocket, which is a reader app, which is an offline reader app, which I use if I'm commuting and that sort of thing. So you can automate all these things so that you're not having to do them manually. So imagine the power of that if we were in a clinical world where we could say, right, when I get a new patient registration, I would like this to happen, that to happen, and that to happen. And I don't want to have to make it someone's job that those things happen, which is currently what happens. You have to get a member of practice staff and give them a task. No, make a computer do it, because computers are great at this. So that kind of level of automation, we just fundamentally do not have. We're not even close in the clinical world, and it's because of the lack of the interfaces. So this is a really nice app to play with. I've got a few uses for it. There's another version of it, another app that does a similar thing called Zapier, which is more powerful, and I use that quite a lot. I can talk about that after, maybe if anyone's interested. Podcasts, just as a general thing. Podcasts are great. So as a busy GP, if I want to stay up to date, I might perhaps listen to the General Practice podcast, or any one of thousands, hundreds of thousands of other podcasts. So I listen to, myself, I listen to a Ruby Rogues, which is a Ruby podcast. Ruby is a programming language, which I use. I also listen to The Smartest Man in the World, which is a comedy podcast by Greg Proops, who you might remember from Whose Line Is It Anyway? The kind of guy who looked like Buddy Holly. He's very, very funny. So you've got something you can be doing, if you're commuting, whether it's by car or whether it's by train, you've got something you can just, pop your headphones in and have a listen. And it's offline, so it's always there on your phone. So I think, I would highly recommend have a browse of podcasts and see what there is. If you're on iOS, then there is a built-in podcasting app, which you can use. There are other ones you can get as well. If you're on Android, it doesn't have a built-in podcasting app, so I would recommend Podcast Addict, which is the best one that I've found so far. And as it says, you subscribe to the podcasts, and it will then tell you when you've got new episodes to listen to, and it's kind of, some of them come out every month, some of them come out every week, and it's another way of keeping up to date. And it's quite low commitment, as in, it's not like subscribing to a journal or something like that where you feel guilty about not having read it. So yeah, there's some other things. I use an online accountancy app, which it's got a desktop interface, but it also has an app. So when I'm out and about, I'm a freelancer, I'm a locum, so if I am putting something on my personal expenses, because the business is paying for my lunch whilst I'm working, then I can just take a photograph of the receipt, and that goes straight onto my accountancy app. So there's none of this kind of like having a shoebox full of stuff to give to your accountant at the end of the month or whatever. And Google Maps, how did anyone get around without Google Maps before Google Maps? Especially as a locum GP, when you get asked to go on a home visit, and it's kind of like you're in an unfamiliar area, and you just know that you can get there. And I quite often walk there if it's at least reasonably walkable, but I can still use the maps. Once I get there, obviously, there's no bloody clinical apps whatsoever, so it's like going back 40 years, but, I can get to the home visit. So yeah, there are some ridiculously obvious, missing clinical applications that would be like, these would be great, wouldn't they, if we had these things? And it's a bit of an interesting discussion as to why we don't have these things. It comes to paying the piper, calling the tune. It comes down to standards. It comes down to structure and interoperability. And there are a whole load of layers of why this is not how it's supposed to be. But like I was saying before, if we agitate enough, we all can get them. We have to make these things a reality. And that is done by getting involved, first of all. So if you're a GP who's not involved in informatics and you'd like to see these things happen, well, you've got ways of agitating. You've got CCGs and you've got commissioning bodies. And there are always levers you can pull. You can come to an NHS Hack Day and you could build one of them and then show it to EMIS and say, hang on, we built this in 2 days. Why don't you have it in your multi-million-pound product? So I've always struggled with Clarity. As for my CPD, there was a bit of a sort of, the RCGP ePortfolio suddenly shut up shop and gave all its customers to Clarity Informatics, which is the platform that I use for my ePortfolio. But I don't like it, and it's a real pain. Quite often you just read something, and it'd be great to be able to sort of clip that to, like the Evernote web clipper used to work. Only yesterday, interestingly, I found out there is a new entrant in that market called 14 Fish. and they do have a web clipper and they do have an app. So that's interesting, but downside, they're still charging just the same as Clarity were for the actual surveys. So if you want to do a PSQ or a MSF, kind of staff feedback or patient feedback, they charge you for those. And I just think there's got to be a better business model than that kind of really lame, pay us this money. There's got to be a better way. We still inexplicably have virtually no proper access to the clinical record when we're in a nursing home. I was talking to one of the attendees here at the course who's just saying that despite months and years of trying and working with their supplier and the nursing home and having a terminal in the place, it still doesn't work. And you're thinking, what do we have to do to get this really, really important piece of information? I mean, what do we have to do? As clinicians, we just aren't shouting about this enough, that we have no access, so we don't have mobile access to the clinical record. We can't prescribe when we're there in front of the patient and we can have those in detailed discussions with them. We have to wait till we go back to the practice because we all recognize that that's probably still safer because we can actually prescribe right on the system as opposed to handwriting something. I mean, this is really bad that we don't have that. There are other things that we could start to get to, clinical messaging, inter-team messaging, inside your GP team, but also then between GP practices or in a CCG area, or between you and the hospital, or, heaven forbid, between you and the patient. All of this stuff could be done. No technical barriers whatsoever. It's all cultural, organizational, it's who's paying for it, it's where's the information going to get persisted. That's the other thing, is that if I have a conversation with a patient, who's responsible for a message that reaches my mailbox at 2 a.m. on a Sunday? And also, how do we make sure that whole conversation is captured and how does it get into the record? But they're not insoluble problems, they're just ones we haven't really agitated enough about. Smartphone-based tools and instruments, I don't know, at least 5 years ago, I was shown an iPhone with a dermatoscope attached to the front of it. And everyone was, wow, that's great. And the first question is, okay, so when I take that picture, which is now personal identifiable data really, it certainly has clinical significance, and I want it to be associated with a patient's NHS number. Where does it go? How do I get that into that, on my desk? And it's criminal that we still don't have a mechanism for that. That's seamless. It should be as easy as share to EMIS on your phone. What's going on? So anyway, there's a bit of rabble-rousing for you. I've got some theories about why. We're a very small market globally, so app developers who want to develop the next Angry Birds of healthcare, they're not targeting clinicians because we're a tiny, tiny population. They are targeting the world. Okay, so UK clinicians, or we've balkanized our healthcare economy so much that an app is really lucky to get even a national platform. It's almost always in a single CCG area or something like that. Well, who's going to develop an app and invest masses of resources when the best they can hope for is a couple of CCGs, not even national, maybe two nations, 4 nations. Wow, you really, to get 4 nation traction in the UK, and that's still only the UK, and we're talking about the world when we're talking about apps. So it's pretty obvious why there's very little investment. The EPR vendors have already had our money, and so present company accepted, of course. They're not interested. I think none of the main players are interested. And so it'll probably take them to be disrupted by a new entrant to actually make any change. You hear that, EMIS? A new entrant. The interfaces that you'd need to be able to do that kind of, dermatoscope passes information in, that's called an application programming interface, or an API. And the real web, the normal world, not clinical medicine, is just full of APIs. That's the first thing people develop when they develop a new system, is this is the API, please develop on it. And they create a whole load of tools and helper facilities to make it easy to develop. for the Facebook API or the Twitter API or the whatever it is, my new thing, API. The interfaces in clinical systems are basically absent. The GPSOC R contract actually stipulates that they have to include some APIs, but because doing so actually undermines the business model of a lot of the suppliers, certainly the exclusivity of access to that data starts to be undermined. So they're not that keen, so hence we've had a bit of butt dragging from some more than others. I'm sure you know, or some of you will know who I'm talking about. So there are some more, I guess, unavoidable or realistic, less market-driven reasons why our apps are not great. You know, the 99.999% uptime for a medical app is absolutely de rigueur from day one. We have to have it functioning perfectly. We can't have an alpha version and then a beta version, and then a few bugs that get ironed out for version 2.01. I mean, even Apple quite frequently put out a software update to the iOS, and the first version of it breaks everything, and the next version is fine. Well, that's not acceptable for medical apps. So we've got a really high bar in terms of QA, quality. Information governance complicates everything, and we still, as we were talking about earlier on today, it's still completely not a solved problem as to how you resolve the problems of data sharing with the right people, not the wrong people, according to consent, but also according to Section 251 and the law, and it becomes such a minefield. As a healthcare app developer, I've got Android Studio and a phone, and I'm going to write something, I have no appreciation of the depth of difficulty I'm going into. So we have this, chronic subacute hyperinfrastructuralism, which I have invented, and you can call it Bohr's disease when I'm dead. So this is just sort of more of a direct illustration of exactly what I'm talking about with this API problem. So Plivo, Twilio, and there's a million others, they are telephony APIs. So their product is an API, basically. That's all they sell. And that allows you to make, place phone calls, send SMS, receive phone calls, receive SMS, and all kinds of clever stuff like that through a computer program. So I can write a computer program that will send an SMS. I've done this. So that is infrastructure. None of these things are consumer-facing apps, but they are the bits you need to make a consumer-facing app. So a healthcare kind of analogy would be e-prescribing. If that was an API, then I, as an app developer, could write the front end to that, knowing that the fulfillment is dealt with. So that's an API. Maps, another API. Anyone have any idea how you go about mapping the world? Like if I had to start now, I'm not sure I would know. I mean, Google did it with the cars, didn't they? Have the right? So you need a lot of cars and the thing, and you know, you need quite a lot of resources to start mapping the world. Luckily, you don't need to, because there's an OpenStreetMap, there's Google Maps, there's Apple Maps, there's a whole load of mapping APIs. So don't use the work. Build on the shoulders of those giants that are there, okay? And then payments, so that's quite a tricky thing to do, high risk. You've got to be able to get a program that can interact with the world's banking infrastructure, which is different in every country. And there's currencies, and there's time lags, and there's all. Nightmare. So PayPal, Braintree, Stripe, and there are lots of others, have done it. So you have programmatic access to payments, all right? Now, so just imagine there are none of those things. And try and build Uber. Okay? You can't. So Uber basically could not have existed. I'm not endorsing Uber. In fact, I'm unendorsing Uber. Don't use Uber. Google Maps, payments from PayPal, Twilio to send SMSs and receive them. Uber, right? They couldn't have done it. If they had had to do those things, build maps, integrate with the world's banking systems and the telephony systems of every country in the world before they can build anything, then their venture capital people would have said, I'm out. Okay? So we aren't there yet in clinical medicine. We're back there, we're in 1997 or something. So these are the things that, this is some of the things that need to exist. All right, the APIs, and almost all of them are APIs. So bookings for everything, okay? But not just the obvious ones, not just the e-referral service bookings, because that's lame and shallow, and we actually need to be able to do like blood tests and physio, and every single thing that you can book has to be bookable via API. Registers, so like who's a doctor? I need an API to check who's a doctor. I need an API that allows me as a doctor to sign a prescription cryptographically so that it's incontrovertible that I signed it. All doable. None of this is new, but it just isn't implemented yet. So these are railroad tracks. Other people will build the trains, but we are the people who have to build the railroad tracks. Governments build infrastructure, and Virgin build trains. So communications, we still don't have a clear idea of what communications, secure communications look like between patients and staff and inside teams and multidisciplinary teams and wider teams across an area and national teams. And we've got NHS mail, which we've been told it is encrypted and secure, but it's not. Literally, it is if you've been, inside your organization, if it's all signed and sealed, you can send to another member of your organization, and that's fine for patient identifiable data. But don't send it outside, because they might not be accredited. Well, what use is that? That's like email that only works in your house. Calculations, so like the MD Calc that I was showing you before, every single one of those should be accessible as an API endpoint. Why? Because some of you will have been aware that a GP vendor managed to misimplement QRisk-2 and have, as a result, over-treated loads of people with statins. Now, that's because they had to implement it. So these things being published as this is a decision tree, now go and implement it in software, that's inherently dangerous. What we should have is an API which provides the answer to your question. You give it the pieces of information it wants, so you tell it whether the patient's diabetic, their age, all that kind of bits of information in the required format. If you don't give it the right types of codes, it will just say wrong, do it again. So you can't submit the wrong codes. You can't misimplement it. You just get your answer back, which tells you the risk, and that's it. And those could be nationally provided, nationally quality assured, clinically assured, which is hugely expensive to do, and open source, meaning that lots of people would look at them. If there was a bug in the code, somebody would find that bug and it would get reported. Whereas, how long was there a bug in TPP's code? There, I said it. Consent, maps, etc. Lots of this stuff sort of exists. Some of the open data that's out there is in Excel spreadsheets, and you can get some of these things, CCG boundaries and stuff like that. Is that any use to anybody? Has anyone tried to superimpose Excel spreadsheet onto mapping? It's hard. It's not something that anybody can do. Yeah. So why don't we just make that easy? Do it once, and then let everybody share it. That's the role of the center. So there are some ways you can get involved in fixing this problem. Obviously, if you work for NHS England, then you can go to a meeting and tell them, this is a really good idea that Marcus has come up with. You should definitely be doing this. If you have influence, then I'm for hire. But also, this group is an excellent way. So if you're a GP who's not been involved in tech before, you need to be. Because actually, tech and medicine are not separable anymore. So you have to understand the tech to some degree. And being even very kind and fair to the members of the primary healthcare specialist group, some of them are at least approaching retirement. Some of them are way past retirement. So we've actually got a bit of a generational gap, really, because in the MP Fit years, basically you were either in or you were nobody. So that cohort is still in health informatics, but there's a big gap where no one could get involved because they weren't in the national program and they weren't hiring. So now you can get involved. So join groups that are interested in this thing. One Health Tech, they basically do tech events, networking events. They're very open and inclusive. Open Health Hub is a forum that I run, which was intended to sort of provide that missing place you can go and talk about things like semi-technical stuff. So some of it's quite technical. It's about fire profiling, and it's about interoperability, and it's about terminologies and things like that. But there's nowhere else that you can just openly discuss that. There are forums online, but they're all closed. So this one's open. The National Health Operating System, which is something that I've been working on since about January, is an Ubuntu variant. So a flavor of Ubuntu, which is a kind of Linux, that has been specialized to work in the NHS. And the idea is to eventually produce a warranted spine environment that's free and on a disk. And that will save the NHS about £500 million over 5 years, we reckon. Not that stopped NHS, not that stopped the Department of Health telling us we couldn't call it NHS Ubuntu. We actually got a takedown letter, which I framed. And I think one day one day that'll look less good to their eyes. So Interopen, that's an industry-wide sort of vendor-driven kind of collaboration to try and get some interoperability about data standards, to get some cooperation about data standards, so that we will have interoperable records, which comes with its own problems, but we have to go there. And come to an NHS Hack Day. The next one is actually this coming weekend, so it's tomorrow. No, it's not. Or is it Thursday? It's starting Saturday, so the 14th and 15th in Gloucester. So if you're around there are still tickets. And that is it's very provocatively called Hack Day, but no one will be hacking into the Pentagon or anything like that. It's more about taking a clinical problem, articulating that to a room full of developers, and then getting some help fixing it. And we've had all kinds of stuff genuinely built at NHS Hack Days that's quite impressive, actually, because of the APIs in the real world, you can do some really quite cool stuff. So we've had real-time medication reminder, SMS alert apps being built over the weekend, and all kinds of stuff. So there are quite a lot of things that you can get involved in if you want to help. So yeah, if you've got any questions, I'm happy to chat.
Marcus, thank you very much indeed. That's an excellent talk. And although I realise you've actually told us there aren't any things that are useful, I feel very enthusiastic about it after listening to you. So any questions for Marcus? Let me pass to the back.
If you could pick on one thing to change, one app to deliver out of your list of many, what would it be?
Wow. If there's one thing I could have today, it would actually be a cross-platform identity agent. Because the problem with almost everything spinewards, so that's e-referral, e-prescribing, summary care record, a whole load of stuff that's nearly there, because they are national web services, and they're almost in the category of an API. They're not quite as accessible as they should be, but they all require the identity agent, the Spine smart card software, and that is Windows only. And it's coupled to Windows via bits of string and a tin can and some nuts and bolts, and it's very ugly inside. So what I'd want is a nice rebuilt cross-platform identity agent. That would mean you could use an Apple Mac for clinical work, assuming your supplier was willing to give you a system that would work on an Apple Mac. But then TPP System 1, for example, is written in Java. It would immediately work. That's just a case of just moving the code. So having that identity agent would open all the doors. You could have a Linux desktop, which would be free. You could have a variety of different Windows desktops if you wanted. You could use other types of free desktop. You could use Apple Mac. You could then also think about mobile, so having iOS and Android. And again, that's one of the main reasons. That lack of the identity agent is one of the main reasons why we don't have the clinical access to the summary care record. I mean, if you're in a nursing home, even the summary care record would be helpful, but you don't have it because there's no IA.
Do you think, Marcus, that with the change coming in structures in primary care, such as federations and accountable care organisations and things like that, and primary care homes, whatever they are, that might produce a disruptive environment that allows some things to change?
No.
That's a good answer.
I think it will produce a disruptive environment in which to work. So I'm a bit of a skeptic about reorganising the deck chairs on the Titanic. So I don't think that any amount of administrative and organisational change will necessarily bring about the things you want to see, unless you are very clear about the things you want to see, because just reorganising an existing organisation that doesn't do healthcare tech very well means you'll create a new one that doesn't do healthcare tech very well. You have to completely reinvent. You have to get clinical acumen injected into those organisations and people agitating about why it's not good enough. And then you'll start to get the change. But merely creating some loose accountability framework, I think, is a sham.
James Sudbury, ST1 GP trainee.
Hi.
Hi, a very good talk, thank you. With regards to sort of cutting through the red tape and sort of getting things out there that you prototype, is it better than in primary care? Because I tried to do that as an F1 and I was just hit by no's and it was very difficult to actually make any changes. Is there anything you'd recommend for primary care that going forwards?
It's a bit better in primary care because I think the organisations are smaller and there are some opportunities to get involved at local level. Excuse me. But the problem is quite prevalent and pervasive, really, especially where IT is concerned, because it's seen as very high risk, it costs money, there's all kinds of difficult things you've got to solve first, like IG issues and security and that kind of stuff. So in many ways, it's just as hard to do anything of a decent size. But that said, getting involved with people who are doing that kind of stuff and have done that kind of stuff. So NHS Hack Day would be somewhere I would say you need to go to an NHS Hack Day, see what it's like there. It's also a very empowering environment because instead of being the only one who's banging their head against the monitor, you're now amongst 200 people who are banging their heads against the monitor. So you feel at least you've got, it's like a support group. So you get that kind of effect. But it means you can learn from each other's kind of mistakes, and there are definitely people going in the right direction with trying to make it easier to make changes. But then there is also, I think one of the things that the innovation crowd don't always completely get is that medicine has seen its fair share of innovation. Like, what was it, radiation. That was a cure-all 100 years ago. You could get a radiation tonic and a radiation lather for the bath, and it turned out it wasn't so great. So we've seen fads come and fads go, and we are quite skeptical and I think appropriately cautious about the new shiny in medicine. So sometimes when it seems like we're moving very slowly, I think it's actually because the standards required of medicine are extremely high, and we're a thousands of years old profession.
Yeah, hi, Raza Tuzi, GP. Hi, Marcus.
Hi.
Can you go back to that slide on required APIs? The one with lots of text on it.
The things that need to exist.
Yeah, just wondering, that seems to be the perfect fit for what NHS Digital, or whatever they're called now, should be doing. They should be having a standard platform that everybody should be focusing on and going into and coming out of. Maybe they'd argue that that's what they're trying to do with GP-SOC. I'm not sure. But from what you know already, what do you think NHS Digital is doing with that slide? And are they doing anything, or do they plan to? It's a question that
I think one of the fundamental problems answering that question is that NHS Digital has a very system-oriented approach rather than a problem-oriented approach. So they've given the GP system suppliers this GP Connect API to deliver, but they're thinking about it very much as it's a one-trick pony. And they're not stepping back, as Marcus has done, and saying, look, to deliver this broader context, what we need is to scope these APIs, not give each supplier a technical specification for their individual API, but to go back and say, this is what the API needs to achieve. Now, you know your system.
Make it happen.
Make it happen.
Yeah. I think that's true. There are, I would say, there's 1 or 2% of this that's actively being worked on at the moment. Things like booking, GP registration, stuff like that. But they're not always being framed as a public API with which you can sign up, get a developer account, generate some API keys. That's the kind of stuff that will drive new developers into the area, and it's a green field for really cool stuff.
They'd probably argue, oh, we've got the spine, we've got GP, we've got Choose and Book, we've got different ways GP can get access, but it's a very enclosed market with only a few suppliers having access to the data and to be quite honest, faffing around with trying to create something collective because it's in their interest to do their own thing.
Yeah, I mean, if you want to imagine a booking service that really works, then you've got to think, how about something that when my patient is given a GP appointment, or when my patient gets their hospital appointment, it will automatically book them a PTS ambulance. So that if this, then that, you invoke that kind of API connecting layer that would say, when this, do that. And then, of course, means that when, as is typical, the hospital cancel that appointment, and then give them a new one, and then cancel that one, and then give them a new one, the PTS will just move automatically. So instead of that being a headache for the family, which is what it is at the moment. So to do that, you can't just have GP booking in a box. You have to have booking, all booking for all things.
Speaking of booking, I'd like to say the airline traffic, booking for a flight. They've got their act together. A few years ago, they did exactly that. They developed an API, get everybody on board, and you can book from anywhere to anywhere through this API. Something we need to look at as well.
I do remember someone saying that, why can't we have a booking system like an airline? And the response was, well, that's fine, but my patients want the jumbo jet to come round to the house.
Yes, James Barrett from Pumice. Can you say something about open source development? We hear a lot about it in the NHS, and we have Linux, and we have Apache, and we have Firefox, but we don't see, say, hospital PAS systems that are open source. Do you have a sort of view on where open source, the place of open source in NHS software?
Yeah, I do have a view. Thank you. It's almost as if I planted I didn't actually plant that question, but yeah, I have extremely strong views about open source, which is that I'm very, very pro open source, and that for the simple reason that medicine itself is open source. So since the time of Hippocrates, the only times we've made progress is when there has been open publication of scientific findings. So notable absences of progress, alchemy. They did a lot of biological experiments, didn't publish anything because they were worried that it would give other alchemists their secrets. No progress made. The Chamberlain forceps, I don't know if you know of those. This is a family called the Chamberlains who had obstetric forceps they invented, and they kept it a secret for over 100 years and passed them down through the family and made a lot of money by going and doing deliveries in a box. They would blindfold the mother. They would prevent anyone else seeing. I thought this was, you can actually go and see the forceps in the Wellcome Trust Museum, or I think a photograph of the forceps, I don't know. But so they would come in, deliver the baby, disappear. They made a lot of noise and sort of jingling sounds and extra sort of artistic noises so that no one could guess what it was. But actually all it was a pair of forceps which you'd pretty much recognize as, they look a bit like Keelan's forceps or something. And they successfully delivered lots of women. And during that time, several hundreds of thousands of women and babies will have died because that innovation was not shared. So that's why I believe in open source for healthcare. So if you come up with a technical solution that saves lives, say you've written a PAS that somehow is so good at its PASing job that it saves lives, and you don't share that with the rest of the world, you're a criminal, not a doctor. That's my view. can you come to some of my other talks? 'Cause I don't normally get that response. It's normally a chilly silence while vendors leave the room. Anyway, EHI Live in November, come to that.
Any more questions? Yep, coming back over here.
The Open Hack Days are brilliant. I've been to one, so I recommend anybody who hasn't to go to them. But just going on from that, it's just amazing that how so many good ideas just go nowhere. You have these good ideas, you kind of say, well, this is good, let's do this, let's go forward, let's do that. Can you cite any kind of reasons? You mentioned a bit in the talk, but why they don't get to the next stage, why they're not taken up? Is it really the main providers in their castles protecting their own little area and not allowing anybody in?
There's a bit of that. There's actually several dozen reasons, because it depends on what's been developed and how far they got and that kind of stuff. But say, at an NHS Hack Day, if something really cool is developed that you think, oh, this is really interesting, sometimes the developers themselves have got other jobs and they've got a full-time job, and they've come and they've donated their time, highly respected professionals that come and do stuff for free, same as the clinicians. The developers are doing a great job there as well. And then they go back to their day job and they're just busy. And the same with the clinicians that helped make that thing. They're just busy and it sort of fizzles out. So there are a whole load of other ones. There's technical reasons, cultural reasons, and there's lots of other stuff. What I think we really, to get some serious progress, we actually need to see a bit of talent spotting at NHS Hack Day. So we still, 5 years in, we've done now 16, I think the 17th Hack Day is the one that's this weekend. And we've never really felt that we've had support from the centre saying, we're really proud that our country has got people in it who are prepared to give up a whole weekend that are coming to donate their time and energy for the NHS. And to reward that, we're going to come along and talent spot good ideas, and we'll make sure that they're supported and seen through to fruition, which is a huge, I think for even something quite basic, you need £500,000 to just get going.
As you build the software up, as you develop it, as you support it, as you patch it. And I think NHS Hack Day is a good idea, but understanding the reality of creating software and deploying it and patching up and supporting it is another kind of kettle of fish altogether.
Definitely. But the existing vendors do that. So a new solution with the appropriate support could get to the point where it can provide a service around its technical solution. So it's all doable, but it requires that amount of support, and unfortunately, there isn't that at the moment. We have the organisation that runs NHS Hack Day has seen this happen, and obviously it upsets us more than anyone else, really, because we're the people who see it every year. The same great ideas go by the wayside. So we've actually started up a little foundation to try and accrue some funds that we can then help good projects and advise good projects and give them some support. But it's a drop in the ocean compared to what's needed, because we just aren't resourced to that level.
Could we have some tooling to assist in crowdsourcing content authoring like SNOMED, CT, RefSets and decision support, so that we can all contribute? Because at the moment it isn't getting done in the important areas that we need, and there's enough of us to do it. So I would open source the content as well as just the functionality of the systems.
Yeah, well, I think I'm in favour of everything being published and open as possible. So to me, open source tooling to help author content, it would be great. It would also enable that shareability. So if I, as a GP, have created a little nifty plugin that connects one useful endpoint to another useful endpoint with my if this then that of medicine, then I can share that immediately with all of the community, and in a lot of similar way to how if this then that does it. I would be able to browse interesting clinical plugins and from other authors, and I'd just say, right, I'm going to try that in my practice and see if it improves whatever.